Hi everyone, I'm Emma Eggleston, Dean of the WVU School of Medicine Eastern Campus. Welcome to tonight's Mini Med School. So tonight we are very fortunate to have Dr. Shano Thaya-Gallingham, one of our geriatricians and assistant professors of medicine here at our Eastern Campus. So Dr. Thaya-Gallingham trained at Rutgers in internal medicine, and after that got his geriatrics fellowship at the Mayo Clinic. And he has joined us and really built out our geriatric services, both inpatient and outpatient. And as I mentioned, tonight he'll be talking with us about depression in older adults, which is a really important topic, particularly now, all the time, but particularly now with the pressures that we've all been through with the pandemic and the isolation that can engender. So I hope you will enjoy tonight's program, and thank you, Dr. Thaya-Gallingham.
Hi, good afternoon. My name is Dr. Shanajan Thaya-Gallingham. I am a geriatrician and assistant professor of medicine at West Virginia University. Today I'm going to be talking about depression in older adults. This is actually a very important topic because more than ever, we're having a COVID pandemic, which is also causing significant amount of isolation at homes, and so the cases of depression has increased in the clinics, and so this is actually a very important topic for the public to understand and learn about. And so I'll go over briefly various highlights that are important for all of you to understand. So I have no disclosures to declare, and in terms of our outline, we're going to go over a few specific topics. One is, what is depression? Next is, what are the symptoms? Why does it matter? What are the causes? And thereafter, the diagnosis and treatment and some local community resources for it. So, what is depression? So depression, very simply, it's when you have persistent feeling of sadness or loss of interest. And not only that, in older adults, what's important to recognize is that a lot of times the classic presentation of depression is not always apparent. Older adults may not have sadness. They may show other signs such as apathy or lack of interest in doing things on their facial expressions, feeling more tired than usual, sleeping in a lot more than usual, and being more quiet than usual. All these may be clues towards depression in the right clinical setting, and so we'll talk further about it, but that makes it much more unique in older adults. So what are the symptoms of depression in older adults? Well, a few key things this picture highlights. One is sleep disturbances. 2, are there weight changes? 3, are there issues with, for example, lack of interest in doing activities that you once enjoyed? Or is there a sense of guilt or worthlessness? This collectively helps the doctor to decide whether a patient has depression, especially in the older adult population. So these are some of the signs that, these are some of the symptoms, rather, that we look for. So essentially, if you were to ask yourself, do you feel tired, helpless, hopeless? Have you lost interest in many of the activities and interests that you usually do? Have you felt this way day after day, etc.? If you answered yes to any of these questions, you may be experiencing depression, and seeing a doctor can help you identify and treat you for this condition. So why do we talk about depression? Why is it important? Apart from what I said earlier about the COVID pandemic causing significant social isolation, in fact, from recent studies, it says that about 40% of American older adults live alone at home, but that's before the COVID pandemic. So why is it a big deal? Up to 10 to 20% of cases of patients that come to the clinic or at nursing homes have a diagnosis of depression. It's quite prevalent, and the impact it has on day-to-day life is also significant. It can affect the things that we typically do. It impairs us from enjoying activities that we like. It could even go to the point where it affects our emotions, our behaviors, and our physical well-being. So I named a few examples here of what they are. These include weight increase, patients experiencing more pain, self-mutilation, family conflicts, and even suicide, and also cognitive decline, specifically memory issues. So all the more reason why it's important to have depression evaluated if you suspect your family members or yourself to have that. So what are the causes? Well, the exact pathophysiology or the exact mechanism by which depression happens is not still fully understood, but what we do know is a few things. Well, if you look at this picture right here, you can see on the left-hand side a brain of a depressed patient, and the bright colors indicate the areas of increased brain activity. Now compare that with the patient who's not depressed, and you can see that the brightness is much more pronounced. And so these are some of the changes that we see in brain activity in those who are depressed. Not only that, we also see changes in the brain chemistry. So we all have about 30 different chemical communications molecules in our brain called neurotransmitters. And when certain ones are impaired, that can also affect depression. So specifically, we're talking about serotonin, norepinephrine, and dopamine. These are the molecules that are currently being targeted by drugs, the common drugs that we typically use. These are the targets that we look into because these are the drugs that influence mood, sexuality, for example, and also well-being. So those are important transmitters that we're able to figure out in terms of treatments. Other causes include hormones. So a patient who has abnormal thyroid levels can also have problems with depression. Additionally, menopause or pregnancy are a few other examples where hormone fluctuations can precipitate or lead to depression. And lastly, inheritance. So many studies have shown that family members who've had depression lead to higher risk in subsequent generations to have depression. It doesn't have to be always the case, but they're at a higher risk. And what's important to remember is we haven't identified very thoroughly a particular gene that is well known to cause this particular risk for depression. However, we do know from studies that family members who've had depression leads to risk in the subsequent generation patients to also have depression as well. So what are the risk factors for depression? Are there things that trigger it or worsen the chances of getting depression? Well, studies have also shown that females are at higher risk for depression. Certain medications can cause increased risk for depression, such as beta blockers. Certain medical conditions, specifically stroke or heart attack, can put you at higher risk for depression. And so it's actually known by doctors to look out or screen for depression in those patients who've had a recent heart attack or a stroke. The doctors will be more on the lookout for those sort of symptoms in such patients. Additionally, poor sleep or even loneliness can contribute to depression. One other important thing is that older adults lived a long life and they tend to see more events in life, such as loss of a spouse, a divorce, changes in life events such as retirements. All these changes in life, a lot of patients can get over it, but some who are not able to get over it, it can lead to depression, and those also are risk factors that needs to be considered. So when you go see a doctor, what are the things that are going to be asked? What are the questions and that will be investigated upon, and what are the tests that will be done? Well, typically there are screening questions that we can use. There are specific ones, for example, PHQ-2 or PHQ-9. These are standardized screening tests that are used in the doctor's office. These can be utilized to get more information. However, in older adults, it's important to remember that they don't have the typical presentation that you would expect of any general population. And so beyond these screening tests, if there is a suspicion, the doctor will consider treatment, even if the screening tests don't strongly suggest signs for depression. Additionally, there are labs that we can do. One that I mentioned earlier was the thyroid test. And in addition, if there is concern for suicidality or if the depression is difficult to manage, the doctor may refer you to a psychiatrist if depression is a concern to that extent. So in older adults, we're going to focus on just a few types. One is major depressive disorder. Specifically, what do we do for that? And also if the patient has delusions or hallucinations, also termed psychosis, what do we do for that? There are other types called minor depression, which is basically a milder version of the terminology used above. And then bipolar disorder is a type where you have depression, but there are also features where the patient experiences very high elevated moods, such as feeling grand, wanting to spend a lot of money, not being able to sleep. Those sort of symptoms can also happen, and that's termed bipolar. And then lastly, grief. We all have patients, we can all have losses in our lives of our loved ones or friends. However, if the grieving or if the worry and thoughts about that loss becomes prolonged for example, greater than 6 months, or if it becomes to the point where it's very severe, it's affecting your day-to-day activities and it's impairing your life, that's called complicated grief, or in medical terms is called complex bereavement. And in those situations, interventions such as medications or therapies indicated. So these are the common ones that we typically see in older adults. So as previously mentioned, some of the signs and symptoms, these include weight changes, sleep impairment, difficulty concentrating, in addition to feeling down or depressed or having loss of interest in doing activities. We usually look to see if this has been happening for quite some time, at least 2 weeks, and thereafter we determine whether is this the first episode or is this recurrence of the same issue again and again, because whether it's the first episode or a recurrence does matter, because treatment duration changes based on that. Now, when we talked about major depressive disorder, that was the first type. We also mentioned earlier about minor depression, which is a milder version of major depressive disorder. The other type is bipolar disorder, in which, as I mentioned earlier, there's episodes of inflated self-esteem, grandiosity, hyperspending, hypersexuality. All these happen under mania, these episodes, in addition to having depression. So those together is labeled as bipolar disorder. Now, in older adults, it's unique is that they may not have these classical kind of symptoms that we know in the general population. In fact, what some older adults may present with is actually delirium, delusions, hallucinations. They may also have sleep disturbances. It is overlapping with many other medical conditions, and so that's why it's much more harder to diagnose in older adults who had late onset bipolar disorder with mania. Now, what are the medications? Well, for treatment, it's grouped into two categories. One is a medication approach, and the other approach is a non-medication approach. So it's good to do both, but we'll talk about the medication approach first. So when we talk about medications, typically we're talking about the antidepressants falling under the categories where those neurotransmitters work I mentioned earlier, the serotonin, norepinephrine, dopamine. Drugs that target that is the medications that we currently use. So this is beyond the scope of this presentation, but I listed the categories of those medications. And then what are the side effects? Well, it's important to remember these side effects because if you are diagnosed with depression, you may be given these medications, and it's good to know what to anticipate if you don't tolerate it well. And it is common in older adults to have these experiences. with various medications and is easily treatable. And there are many medications that can be switched over if you are dealing with these symptoms. So what are they? Well, it increases the risk for falls. There's increased risk for nausea and diarrhea. There's also increased risk with sexual problems. So there may be decreased libido, decreased erection in the men, for example. And also weight changes can also happen due to the medications, depending on which one you're on. Now, as I mentioned earlier, duration matters. So if this is your first diagnosis of depression, usually once it's resolved, we treat for additional 6 months and we can stop the medications thereafter. However, if you're having recurrent depression, or if there is psychosis, in other words, hallucinations or delusions, then in those situations, we actually may want to continue the medications for several years or even lifelong, depending on how severe it is. And the doctor can decide, based on your clinical examination, how long to continue it for. The other aspect is genetic testing. This is interesting. In recent years, there's been a progressive evolution of the availability to do genetic testing. What that means is essentially certain drugs are broken down in your body much more quicker, and certain drugs are not broken down as fast. And so the duration of that medication in the body can impact the dose that's needed to adequately treat you. If, for example, the standard dose is 10 milligrams of a drug, but your body is rapidly metabolizing it, it won't stay in your system to give enough of an effect. And in those patients, a higher dose is required. And so genetic testing is now done in patients who have difficulties with medications where they're not responding adequately. Right below, in addition to the antidepressants, I mentioned a few other categories of medications that are given, namely antipsychotics and stimulants. These have a role in treating depression, and the doctor can help guide you on when those are appropriate. In addition, there's also other drugs that are used specifically for bipolar disorder, and those include things, medications such as divalproic acid or lamotrigine. And these drugs are not discussed here, but they are also used in bipolar, and their role and their indications, the doctor will decide if it's appropriate. So, now that treatment has started, what happens next? Well, it's important to remember that antidepressant drugs take typically up to 12 weeks to see the full benefit. However, in the first 4 weeks, after 4 weeks of treatment, the doctor can evaluate you and see whether you're responding adequately or not, or have no signs of improvement. In fact, some studies suggest that at the 4th week mark, most patients, if you were to look at it statistically, about a third of them would not respond to the drug at all. 1/3 would have some response, and another third would have a complete response. And so that kind of gives a clue of how the rest of the 12-week period is going to be like, and it helps the doctor anticipate and adjust your treatment strategies. So it's important to remember that 12 weeks is how long it takes to see the full effect. The first 4 weeks can give you a clue in terms of how well you're going to respond to the drug. So we talked about medications. Well, let's talk about non-medication approaches. Many of you may have heard of the electric shock, as some would call it. The medical term is called electroconvulsive therapy. It's where a very specific electrical current in a very controlled manner is given to the brain to help reset some of those neurotransmitter chemicals that we talked about earlier. It's used in many instances for depression, but it's not common enough that many people don't know about. So what is it? Well, it's basically, as you can see in this diagram, a few electrodes are connected to the brain. A machine measures the activities of the brain, and a machine right here gives the electrical current in a controlled fashion. Who is a candidate for it? And that would be someone who has serious risk of suicide, a person who is not eating at all and it's very severe to the point it's life-threatening. These could be even in patients who are pregnant, for example. And also delusions. So if a patient has depression with the delusions, which I mentioned earlier as part of psychosis, such patients actually have about 80% response rate with this particular therapy. Now, it's actually, as I mentioned earlier, it's commonly used, but many people don't know about it. It's pretty good for treating depression and bipolar mania, in addition to these indications I mentioned above. One issue that you may face when you do get the therapy is that you forget, after the therapy is given, you forget immediately what happened before the shock therapy was given. So before the ECT treatment is given, what the events immediately before that, those are forgotten after this therapy is done. That's called retrograde amnesia, whereby you forget past events, but this is specifically just before the therapy. Those events, that's what you forget. In addition, anterograde amnesia is something that's where you forget memory that forms after the shock. So any new information that you learn, for example, you have tendency to forget that. That does happen here. However, over the course of the weeks as the treatment is going, that particular issue actually improves and it resolves. It's more the retrograde amnesia or forgetfulness of what happened just immediately before the shock therapy. That's what persists. However, it's important to remember that in patients who do get in this particular conditions, it actually in the long term helps improve memory, and that's thought because depression is actually being treated and it's getting better. And it also has no lasting cognitive effects on the brain. One other interesting fact is that in some patients who have depression, this is actually used as a maintenance therapy. That's how commonly it can be used, and that's how safe it can be. Other technologies that are being used that are newer but less common, one example is repetitive transcranial magnetic stimulation, whereby a device, an electric coil, is held above the brain and it stimulates particular parts of the brain to help reduce the impact of depression. It's not as effective in older adults compared to the younger populations, and actually the electroconvulsive therapy is actually more effective compared to this. So next part of the treatment strategy when we look at non-pharmacological treatments is therapies. So when I say therapy, specifically, for example, we're talking about cognitive behavioral therapies or interpersonal therapies or psychosocial interventions. These are therapies that are offered by a therapist, and the objective in these cases is a few folds. If you look at all of them in collection, they help with coping, they help with problem solving, they help reduce negative beliefs and replace it with positive beliefs and positive attitudes. Additionally, they also help set goals in life, and all these collectively help improve the patient's depression or the impact of the depression on the patient's life. So it is important to do if it's available in the local community. A new trend that's happening right now over the past few years is called disease management models. What that basically means is a team of healthcare specialists, specifically a therapist, a nurse, or a doctor, a psychiatrist, work in coordination to help improve your depression. The nice feature is that most of these can be done by the phone. So screening questions or follow-up questions can be done by telephone, and once that's done, the doctors or the therapists or the ones who are calling you can see how you're progressing. And this actually has been shown to be quite effective, and this is where a lot of healthcare's depression treatment is heading towards. When it comes to community resources, there are many resources available. First of all, when we look at social isolation and older adults living alone at home, there's various community organizations and agencies that are involved with doing, for example, phone call check-ins or coming into your house to see how you're doing. Or for example, if you look at the Berkeley County Senior Center, they have a daycare program where the seniors can go to the daycare center to interact with others and have a social time. This is one aspect. If your depression is to the point where it's very severe and you're having suicidal thoughts, you should call 911 or go to the nearest emergency department to get help. There are help. It is treatable. The impact can be reduced. Your life can be saved, but it's on you to get the help. If you have a family or a friend or even a doctor, someone you trust, you should speak to them and open about your feelings, and don't keep it inside, because this is, again, a treatable disease, and it can get better. And a lot of times patients don't speak up because they keep it within themselves. There is a National Suicide Prevention Lifeline phone number that you can call if you search this on the internet. This particular number right here you can also contact, and there they have a crisis worker who can help give you resources and direct you to the right place to get treatment and help. So there are a lot of resources out there that are available. We just have to reach out and get the help if you feel that way, or if you know someone else who's going through this and they need help. So what are things that we can do to help prevent depression? There's no major strategies that are proven to completely prevent it, but here are a few tips that I suggest that you can do easily at home that can help reduce or prevent it to the best of the abilities it can. One is reduce the stress in your life. Try to break things down and make it more simpler to help handle situations in life. Two is having a social circle. If you're able to, talk to family or friends, especially when you're having a difficult time, or even help them out if they're having a difficult time. Three is during exercise. Exercise is actually really important. It's actually one of the therapies that are recommended. So aerobic exercise or increasing your heart rate, whatever the activity may be, to the safest manner that you can do it in. And lastly, just remember that if you can get treated for depression early, it will reduce the impact on activities and your daily emotions and your behaviors, as I mentioned earlier. And so treatment early is important. So if you have forgotten everything I said, well, this is a summary slide that you should pay attention to. So what is the importance of depression? Well, the impact of it can decrease your quality of life, increase the risk of suicide, and decrease your cognition, decrease physical activity, and your social day-to-day activities with others. What are the symptoms? Feeling sad, down, or depressed, having lack of interest or pleasure in doing things that you used to enjoy, not participating in activities that you once enjoyed, losing appetite or weight, having sleep changes, and lastly, having difficulty with concentrating on things like reading a paper or watching TV, for example. And when it comes to treatment, usually is twofold. One is a non-medication approach with the therapist. Another is a medication approach with pills. And another non-medication approach is electroconvulsive therapy, which many don't realize, but it has significant benefits in the right patient population, even in older adults. So this is a summary of basically depression in older adults, and these were the references that was used in preparing this presentation. If you have any questions, you can always contact our clinic, West Virginia University Internal Medicine Associates in Martinsburg, West Virginia. If you have any further questions, you can direct it to us, or you can talk to your local healthcare provider for more information. Thank you, and thank you for listening.